So these are very, very important structures. We had to negotiate and to reach our target areas. Also, anterior to our target areas, we have very important structures. We have our kidneys lying over there. We have our major vessels over there. So we need to understand all these anatomy very, very well. So that is important for the spine endoscopy. We need to remember that each level is a different challenge. It's not same everywhere. For endoscopy, we need to know the transverse sections at each level. At each level, the facet orientations are different. The size of the disc is different. The orientation of the pedicles are different. So that will change your entry points. That will change your inclination, the angulations. So everything will change depending on the site where we are doing. Not only that, it also depends on the pathology, whether it is a central herniation, paracentral herniation, foraminal herniation, or extraforaminal herniation. So everything will depend on that. So we need to understand the anatomy very well at each level. Now you can see on this MRI sections, you can see this, the retroperitoneal structures. You can see the muscle mass. They are totally different at each level. So that is why it is important to understand the anatomy very well at each level. We have some important vessels around. Okay, since when we go for the transferal approach for the transferal neuroplasty, we may not encounter any vessels, but here we are going to put our scope, we are going to put our working channel, the dilator, everything we are going to put over this into the foramen or the interlaminar space. We have some important vessels over there. So we must understand this anatomy very well. We have already covered in the anatomy section, but just for the sake of showing that these are the various important arteries which are there in the foramen area. So we may encounter these arteries. The good part is these arteries, they travel along with the nerve root in the upper part of the foramen, which is not our target. Unlike transferal neuroplasty, where our target is the upper part of the foramen, where when we do endoscopic decompression through the transferal approach, our target foramen is the lower part of the foramen, which corresponds to the disc area. So that is a good part, that we do not have any vessels over there, but at times we may have aberrant vessels. So these aberrant vessels may be the connecting vessels between two radicular arteries, which may travel through the Cambian's triangle. Okay, so we need to understand this. So this is the foramen area. So we know that foramen is basically bounded by the bony structures all over, except for this part which is covered by the disc. So this anterior, posterior, and the superior, inferior, this also changes at each level. Usually the anterior posterior remains fixed around 7 mm. That's why we use a 7 mm scope over there, working channel. And this is the area where we have a nerve root and the vessels over here. Whereas in the transforming approach, our target area is this part of the foramen. So this will change. This will change with the level also, and also with the position of the patient, and also with the pathology. If you have this, please mute yourself, guys. If you have a disc denuation, there is a thinning of the disc. In that case, also again there is a shortening of this foramen area. Also with the position, if we reduce the lordosis, we can open up the foramen area. Okay, like as we do for all the interventional procedures. So when we do knee spine interventions, we reduce the lordosis. How we do that? By putting a pillow under the abdomen. Okay, we try to reduce the lordosis. When we reduce the lordosis, we open the foraminal area. But here we will not do that. Here we cannot do that. Why? Any reason for that?
Abdominal pressure will increase.
Very good. One is the abdominal pressure which will increase. What will happen with the abdominal pressure?
Blood bleeding, chances of more bleedings, surgical bleedings.
Chances of
Epidural
Bleeding.
engorgement.
chances of what?
Engorgement of the vessels and
Yes. Engorgement is yes. Very good. So that is one reason why we should not use a pillow under the abdomen and try to reduce lordosis. So what is the best option? We keep the abdomen free. So for that we can use a Wilson frame. Okay. With the Wilson frame, you can reduce the lordosis also, and you can keep the abdomen free. Okay. Another reason why we should not use the pillow under the abdomen, because that will push your retroperitoneal structures posteriorly. Okay. So whenever you go into the foramen area, that time everything is under fluoroscopic guidance. We cannot see any other thing. So till the time we reach and we put our scope, everything is almost like a blind procedure. The patient is in prone position, the C-arm is in AP position, and we are going from the posterior lateral areas. Okay. So that will push the retroperitoneal structures posteriorly. So there are chances of entering into the retroperitoneal structures. So that is why we should keep our abdomen free. Okay. With affection, all the diameters of the IVF, intervertebral foramen, are at the maximum. So that is the reason why we want to reduce the lordosis also. But remember one thing, whenever we try to reduce the lordosis, if we are not reducing lordosis or if we are reducing lordosis, our angulation or the distance from the midline also changes. So a lot of things changes with the pathology, with the positioning. Okay. So the idea is basically that what I'm trying to tell you is that there is nothing fixed. You just cannot go by the fixed that from midline for L5S1 I'll go at this distance. This is not fixed. This is a general idea which is given in the books. But everything changes with the pathology also, with the where is the fragment line, what is our target? Our target is the inside the disc or outside the disc. Everything will change with that. Interlaminar window. So this is another approach what we use is the interlaminar decompression. Okay. Interlaminar is good for L5S1, which is actually difficult for the transfemoral approach because of the iliac crest. With the iliac crest, if it is high iliac crest, then it becomes almost impossible to reach our target fragment, except if it is in the foramen area. But if it is in the paracentral area or the central area, it is almost impossible to reach there. So in such cases, especially with the L5S1, we must learn interlaminar approach. Okay, interlaminar is good for the L5S1 or L4 L5. As you start going up, you can see here the interlaminar window is getting narrowed down. Okay, because your facets are coming on their way. Facets are getting narrowed. You can look at here. The inferior articular process is so medially oriented, right? But look at here. Okay, so as we start going up, it will start taking a shape like this. It will start going more medially. So the interlaminar window becomes narrower and narrower as you start going up. So it becomes difficult to perform these procedures, interlaminar, uniportal interlaminar approach for the L2, L3, L3, L4. But we can easily perform these procedures at L4, L5 and L5S1 level. Okay. This is what I was telling you about the aberrant vessels. You may encounter these aberrant vessels through the foramen area also. There's a concept which is called the working zone area. The working zone area. The Camden's triangle is actually not the working zone is not a triangular area. It's almost a square type of area. But whatever is most commonly taught is the Camden's triangle. So what is Camden's triangle? This forms the Camden's triangle. The exiting route,
Hypotenuse.
the traversing route medially, and at the base we have the vertebral body. So this is the area from where we enter into the either the disc or into the canal. That will depend on where we are targeting, where is the fragment. Either we go inside out or we do outside in. Okay. So these are the two different approaches. We must know our MRI very well. MRI is going to tell you where exactly is the fragment, because our target is the fragment. Fragment means the herniated portion which has come out. That is the fragment that we have to target. Okay. Endoscopic discectomy doesn't mean that we go inside the disc and try to remove the material from there. That is not endoscopic discectomy. Endoscopic discectomy is ideally to target a fragment. We want to remove the fragment which has come out. Okay. So not just the axial sections, not just the sagittal sections, but we also must know the coronal sections also. Coronal sections will tell you about the fragment, where is it lying, and it will also show you the relation of the dura, relation of the herniated portion with the dura, relation of this fragment with the nerve roots. Okay, especially when we go for the interlaminar approach, that time this coronal section is going to be of great help. So not many times what happens that the fragment which is there, which pushes the nerve root upwards or medially. So we have to see in the foramen, in the window, interlaminar window, where is the fragment lying. Accordingly, we have to select our entry point. At times, we may need to cut the bones if the portion is migrated upwards or downwards, or it is going towards the foramen area. In that case, we might have to cut the bones. That is also called a laminotomy or a facetotomy. We might have to remove the inferior articular process or the superior articular process. Some portion, not the entire portion. We want to preserve the stability. We don't want to do much destruction. The idea is not to do much destruction. Idea is to preserve the natural structures. Idea is to preserve the ligaments. Idea is to preserve the facet joints and the bones. And that is possible only if you know your MRI very well. If you know where is the fragment lying. Okay, so that's why it is very, very important to understand the MRI very well. Your MRI lecture is done? MRI lecture is done?
No, sir.
Not yet? Okay. It is there in the program, no? Is it there in the program or not? Anyway, if it is not there, I'll include that also. Okay? Just remind me. So these are the axial sections which will tell you about the angulation. Suppose if you are performing a procedure to the transforamen approach to the foramen, now the angulation will depend on where is the fragment lying, whether it is central herniation, paracentral, foraminal, or extraforaminal. The angulation or the distance from the midline, that will change. So let's say it is L4, L5. Okay. The general saying is that for L4, L5, go from around 10 centimeter from the midline. That is not correct. If it is a foraminal herniation, if it is the extraforaminal herniation, 10 centimeter from the midline, you will bypass the fragment. And you will be searching your fragment somewhere here inside, which is you will be doing more harm than good. Okay. So depending on the fragment also, we have to choose our angulation. So what are the indications for the spine endoscopy? Indications are where we have a large disc herniation compressing the nerve roots. Suppose if it is a contained disc herniation and compressing the nerve roots, patient comes with the radicular pain with radiculopathy, maybe some mild numbness or paresthesia, where we see that on MRI sections, we see that nerve is getting compressed. So these are the indications where we have to, even the annulus is intact, if it is not extruded. In those cases also, we can go for the endoscopic decompression. In that case, we can go directly inside, we can do the core decompression. Because in such cases with the content disconnection, we want to preserve the annulus as far as possible. Okay, if you try to remove it from here, we may have to do a lot of laminectomy. We may have to do a lot of annulotomy. We need to cut the annulus. Lot of cutting of annulus is required. So in such cases, we may have to go directly inside the disc and we can start decompressing it from the inside. In fact, this is the only indication for the inside out technique. This is the main indication where we go inside the disc and try to decompress the disc from inside. Okay. Or if you have a extruded fragment, obviously there is no point of doing anything in the interdiscal areas, whatever it may be, ozone, disc decompression, whatever it is. That is not our target. Our target is not a disc here. Our target is a fragment. Okay, so in this case, obviously this has come out, fragment has come out. There's a big herniation, big fragment over here. The transformer neuroplasties, usually they do not help in such conditions. So we have to give definitive treatment to the patient. If we see the herniation is big, herniation is compressing the nerve roots, patient is having radiculopathies, there is no point of trying the transformer neuroplasties in such patients. Until this patient is, there is some contraindication for the endoscopic decompression. In that case, we make a go further as a trial to give the patient some relief. But if we find such cases, it is better to go for the decompression. Okay, because we want to give a definitive treatment to the patient. Now we are not just giving the supportive treatments or supportive therapies or the supportive interventions. Now we have reached to the stage where we are giving some definitive treatment to the patient with our pain procedures. Okay, another indication, if you have a sequestrated disc. If you have a sequestrated disc, obviously there is no point of doing something here. We have to remove this fragment from here. Now this migration may be upwards, downwards, or even at times it goes posteriorly also. It may reach to the posterior epidural space also. So this fragment, where it is lying, we have to go and approach our target, our fragment, and we have to start our interventional procedures, endoscopic procedures, the angulation, the angulation and the distance, everything will change with that. Also, we have to select, depending on the type of the herniation, whether I can do transferal approach or I have to go interlaminar approach. So you must know this thoroughly. A thorough understanding of the MRI is must for the spine endoscopy. We do have some contraindications. If it is transferal approach, these are relative contraindications. If this is desiccated, if you have a very narrow foraminal area, that becomes a relative contraindication for the transferal approach. Or if you have a very narrow interlaminar area, that again becomes a relative contraindications. These are not absolute contraindications because now we are doing most of these procedures through the endoscopic only by doing some bone work. We are creating a space and then we go inside. But definitely for the few 50s, 100 cases, it should be a relative contraction for the beginners. Motor deficit, if it is used to be absolute contradiction, but nowadays we are also doing those cases also, because now with the advancement in the procedure, we can do proper decompression, especially with the interlaminar approach. You can do a complete decompression. Even in the stenotic compression, we can do standard decompression. But again, for the beginners, if there is a motor deficit, it is better not to touch such patients. Either you send them to the experienced pain physicians who have been doing this endoscopic procedures regularly, or send them for the open surgical decompression. Okay. Another relative contradiction is here for the beginners is the post-surgical cases, post-operative cases. This is what I was telling you. For L5S1, if the iliac crest is high, then again, it is not a good idea to go for the transfemoral approach. It is always better to go for the interlaminar approach, especially for the L5S1. At times, the iliac crest is so high that you may have to get some angulation for the L4, L5 also. So, if you are good in, if you know about the interlaminar approach, so in such cases, it is better to go for the interlaminar area rather than going for the transfemoral approach. If you have a condition like this, a central herniation, big herniation over here, again, it is better to go for the interlaminar approach rather than going for the transfemoral approach. We can do transfemoral approach. We can extract this material through the transfemoral approach also. But again, we have to see the angulation. If you are getting a good angulation, yes, we can do it. Especially for the L2, L3, L3, L4, we can do very easily through the transfemoral approach. But for L5S1, it's difficult to remove this through the transfemoral approach. Listhesis is a contraindication. Most of the time, when we have a listhesis, patient will have bilateral symptoms. Okay, in such cases, fixation is definitely the best option, especially if the listhesis is mobile listhesis. In most of the cases with the listhesis, the bulge which what we see on MRI is a pseudo bulge, and it is not a disc which causes compression. It is a listhesis which is leading to the stenosis. So we had to go for the fixation in such cases. Yes, in some stable conditions, stable listhesis, grade 1, grade 2 listhesis, at times we see it's not a listhesis which is causing compression, and if listhesis is stable, it is a phlegm which comes from the posterior and that starts compressing. In that case, we can go from posteriorly and we can remove the phlegm from there, and we can give a good space for we can do some good decompression. But for that, we have to ensure that the listhesis is stable. If it is unstable, then better to go for the fixation. Okay. At times, we do these kind of cases, especially for the patients who are not fit for surgeries. In those cases, we do this posterior decompression. The approaches are inside out and outside in technique. That again depends on the type of the herniation, the type of the fragment. If you look at this MRI, if you have big herniation over here, in this case, obviously we would like to go inside and we try to decompress it from here, rather than doing a lot of annulus opening. I can go from side, I can go inside, and I try to remove the fragment from inside. But if you have a fragment like this, obviously it is not possible to remove this fragment from inside. There is no point of going inside the disc in such cases. In these cases, we had to go far lateral. Okay, we had to go far lateral, and we had to go directly inside the canal and try to extract a fragment from there without entering the disc. Okay. So what is the difference? The only difference is that we have to choose a far lateral approach so that we can go inside the canal. Again, it depends on the migration, migrated upwards or downwards. Paracentral herniation, central herniation, foramen herniation. Which nerve to decompress? Also, we have to see that which nerve is getting compromised. So for that, it is called one is the extraforamen approach. Okay, which is a far lateral disc. Now suppose there is a disc herniation over here. Okay, whether it is L4, L5, L3, L4, whatever it is. In that case, there is no point of going inside. There is no point of going like this. If you go like this traditional approach, in this case, what will happen? We'll bypass your fragment. We'll be searching your, we'll be decompressing from here, which is not your target. The fragment is still there. In this case, I may have to go very near to this midline. Okay. Transforamen approach through the foramen, we can either take care of this central, paracentral, foramen herniations. All these we can take care from the foramen transforamen approach. For the superior migrated disc, inferior migrated disc, again we can use the transforamen approach. Okay. So this is again divided into exiting root approach and the traversing root approach. Exiting root approach means where the exiting root is getting compromised. In what all condition it will get compromised? Even if it is paracentral herniation, in the paracentral herniation, most commonly which root is involved? Exiting or traversing?
Traversing.
Traversing, right?
Yes.
Mostly it is traversing which is gets involved, right? But if the herniation is there and is migrated upwards, in that case, it may spare the traversing route and it may get involved the exiting route. Okay, in that case, we may have to go a slightly different angulation. Again, for the downward migrated disc. In this case, again, we have to take a different angulation. Okay, we don't have to search it over here at the disc level. We have to take a different angulation. So this we have to decide from the very beginning, from the puncture side, when we go with the puncture needle. From that time, we have to decide. And that is only possible if you know your fragment, if you know the MRI, where it is, where is the fragment lying. Okay. The traversing root approach, paracentral disc, central disc, and inferior migrated disc. In such cases, we have to go for the traversing root approach. And another approach is the interlaminar. The interlaminar approach, as I mentioned, for L4, L5, L5S1, it is a very good approach. Whether it is a foramen herniation, whether it's not extraforamen, but foramen herniation, or paracentral or central herniation. In this case, we have to look at the fragment. Now, in interlaminar approach, again, we have different types. Where is the fragment lying? Whether it is lying behind the dura, or it is lying between the dura and the traversing root, which is S1 root, which is called the axillary approach. Okay, or if it is lying in the foramen area and is pushing the root medially, the traversing root medially. So that is a shoulder approach. So again, what will happen in this case? Our entry point will change. Whether I have to go from near to the spinous process or I have to go near the facet joints. Okay. All right. At times we have done some cases where the fragment is lying and it is such a big fragment which goes into posterior part also. The moment you open the flavum, you start getting the fragment there. You can start seeing the fragment over there. Okay. But yes, definitely when we do interlaminar approach, that time, normally what I do is I go with the epidural. I put epidural first because we had to handle the dura, we had to handle the roots. That is very painful. Okay, so this is the only area where I use epidural. Otherwise, for transfer approach, we don't use epidurals. We just do under local anesthesia. But here, you will have to put a epidural to basically numb the nerves and the dura over there. Okay, because you have to search the fragment. You have to go in between the dura and the nerve root. You have to search the fragment. You have to extract the fragment from there. You may have to use a hook to extract the fragment. We must understand all the equipments. It is always better if you want to try if you want to start your practice with endoscopy. Once you learn it well, once you have done a good training, if you start your practice with endoscopy, you must buy your own equipments. Don't depend on the instruments which are brought by the on rent. Okay, buy your own instruments, understand them well. There are different type of scopes for different approaches. For transferal approach, we have different scope. It's a longer scope as compared to the interlaminar. For standard decompression, we have a wider board, maybe 10 mm outer diameter. For rest interlaminar, we can use 8 mm outer diameter. For transferal approach, we can use 6.5, 6 mm outer diameter. Okay, so there are different types of scope which are available for the different pathologies and the different approaches. At times, we may have to use these caissons. We may have to use the burr. Some people are more comfortable with using burr. I am more comfortable with using caissons. I use mostly for bone work, I use the caissons. But if you're not comfortable with the caisson, you can use burr. Burr is definitely much safer. The tower, usually you have tower in every hospital, so you don't have to invest for the tower. But these all equipments for the forceps, there are different types of forceps: straight forceps, curved forceps, upward forceps. Okay, so all these forceps are there which are available, and you must have these all different kinds of forces available with you. Endoscopic decompression definitely is a more invasive procedure. More invasive procedure. Complications are bound to happen with this procedure. So that's why the training is really important here. By just attending 1 or 2 workshops here and there, you should not start doing endoscopic decompression. For that, you must learn under guidance of some experienced pain physicians who have been doing regularly endoscopic pain procedures. Then only you'll be able to see some complications and how to manage them also. Okay, so complications, it's not very common, but yes, we do end up into complications. Okay, infection is one of them. Discitis is one of them. There's a possibility of that. All the chances are very, very rare because we use continuously using the irrigation fluid. So with the continuous use of this irrigation fluid, the chances of infection are actually very rare with the endoscopic decompression. Chances of bleeding is there. Mostly it is a venous bleeding. We can use your bipolars to control that bleeding. But if it is an arterial bleeding, it becomes difficult to control that because that will actually you won't be able to see anything. So you must not keep on trying with the bipolar. If you're not able to see anything, if you can see that it's a pulsating bleeding coming from inside, okay, try to put your dilator inside, stay there for some time, 2-3 minutes, and then remove it. Usually that is sufficient. If it is arterial bleeding, it will stop. You may have a big clot over there, you can remove it from there. But if it still continues, you should not keep on trying. Okay, although it is again very, very rare to get an artery to uncontrol the artery in the spine endoscopy. It's very, very rare. Another rare complication is the dural tear. Dural tear is more commonly seen with the interlaminar approach. So when you're cutting the flavum, when you're extracting the fragment, that is the time when you may make a nick into the dura. Okay, especially we have seen dural tears in the chronic conditions. If it is a very chronic condition, if it is a fragment is calcified, in such cases we may get a dural tears while extracting the fragments. So remember that if you see the fragment, if it is very hard, don't try to remove it. Better to leave it and send the patient for the surgical open decompression. Okay? Especially for your first 50, 100 cases, you should not even venture into such conditions where we see that fragments are calcified. You may not be able to detect them on the MRIs, but when you go inside, that at times you can easily make out that it's a fragment which is a calcified fragment. Okay, because this is the time when you try to cut this fragment, you may end up into some dural tears or the nerve injuries. Okay, so know the complication, know how to manage them. That is important. Take the help of the seniors. Whenever it is required, whenever you are suspecting any complication which has happened, immediately send the patient for the fresh MRI, contrast enhanced MRI. Detect your complication on time. Mention it. If you have identified a complication, you must mention it in your case sheets. When the patient comes for follow-up, patient comes with the increase in pain or some deficits or some leakage from the suture side, you must send the patient for immediate for MRI, identify the complication, mention the complication, involve other people. Refer the patient to the surgeons if it is surgical intervention is required. Okay. So not managing a complication is a negligence. That is most important part. That's why it is always better to write everything. How you are managing this, how you are taking the help of others. So if you don't write all these things, in that case, it becomes negligence. Okay. And don't be afraid of adopting and learning the advanced procedure. This is the future. You have to learn these advanced procedures. We have to go for the definitive interventions now. Okay, guys. This is all the basics of the spine endoscopy. As I mentioned that in the exam also, you will be asked very basics of the spine endoscopy. We are not going to go into details of the spine endoscopy. Even in the Viva, if the examiners will ask, they will ask only the basics. That whether in such conditions, whether you would like to go for the endoscopy or not. If you want to go for the endoscopic intervention, which approach will you do? Okay. They might ask you about the complication. What are complications are possible with endoscopy? They might ask you about the MRI. We can show you the MRI. Where is the fragment lying? What will be the approach for the spine endoscopy? So these are the very basic questions which you are going to ask in the exam. Okay. Any question?
Sir, you have given very good insight of the topic.
Thank you, Anshul.
Yes, sir. Yes, sir. Sir, I have to add something that one thing that you have told that we can send some cases of hard disk to the surgeons. Mostly there is a classification that after that there is a paper which defines that which cases can go for transforaminal endoscopic discectomy and which patient can go for interlaminar discectomy. And after reading that paper, we can decide that these are the patients for transforaminal endoscopic discectomy. We can go for that these type of patients for transforaminal endoscopic discectomy. And I don't think that in matlab, I have done, I think, 300 or 500 cases of transforaminal endoscopic discectomy in which I seen never seen that there is any calcified disc, or I have to refer this patient for the
See,
surgical intervention. If we plan meticulously, uh,
Anshul,
if
I understand your
yes,
emotions, but this lecture is basically for the FIPM fellows.
yes, sir, yes,
है ना? So these are for the beginners.
yes, sir,
So
yes.
for the beginners, it is always better to tell them the basic things, and we have to be careful with them.
Initially, they must have someone with them to start with. Everybody done
Yes, absolutely.
the endoscopic cases in initial learning curve like that only. So better to have someone with us in initial 10 to 50 cases,
हाँ,
or whenever we feel difficulty. Sir, there are some questions for you.
हाँ.
Can you please mention which approach is in interlaminar endoscopy at L5S1, axillary or shoulder? It is
Building the
dependent on the fragment location. Actually, we have to read the uh, MRI first.
Yeah, that is the most important part. As I mentioned, that the fragment, we have to see where is the fragment line. Okay, that is one approach. I think somebody is mentioning about the iliac crest, right?
Yes, sir.
The transfer for the transfer approach. Yes, that is again one of the approach. But let me tell you, this approach is not a very good approach because it is very painful also, and it's very complicated also. Better to learn the interlaminar. L5S1 interlaminar is the best. You can see everything in front of you. You can do proper decompression. You can see the nerve root. You can see the dura breathing properly. So instead of going and drilling the iliac crest and entering the foramen, and I would suggest not to do that. Better to go for the interlaminar.
Sir, I differ in this opinion, please, if I can say. If we can read one paper in which we can do transiliac and in which cases we go suprailiac, there is a good classification of that if iliac crest is going above the L4 पेडिकुलर लाइन एंड मतलब एपी और लेटरल का एक बहुत अच्छा सा क्लासिफिकेशन सिस्टम बताया हुआ है ट्रांस इलियक और सुप्रा इलियक के बीच में, तो उसको समझ के अगर अपन जाए तो ट्रांस इलियक बहुत इजी है, कोई समस्या
That
नहीं
is
होती.
there, but if you see now, since we are doing interlaminar, na, since we
Yes.
started doing interlaminar, in fact, nobody is doing transiliac now. Hardly
Yes.
anyone is doing transiliac now.
Sir, trans iliac is necessary when we wish to do fusion endoscopically in MIS
That is
endoclif
trans,
cases. So
fusion
मतलब
is okay.
at a time patient at a time मतलब surgeon must know or physician must know how we should do it.
Fusion is different issue.
Yes.
Fusion is different. In fusion, we had to go inside the disc and we had to go for the remove the disc material completely.
Other thing is foraminal and extraforaminal disc of L5S1, in which we need transforaminal surgeries only, either transiliac or suprailiac.
How to find and manage the dural tear intraoperatively? See, it is very difficult to see the dural tears intraoperatively. At times, we may be able to see, but since we do not have many complications which we have seen intraoperatively, but yes, definitely we can see them intraoperatively also. But most of the time, what happens that whatever the dural leak is there, that is very small. Even the dural leak which happens intraoperatively with the irrigation fluid what we are giving, it is very difficult to identify that dural leak. Mostly, whatever I've seen the dural tear, mostly we detect them post-operatively when the CSFs will start collecting and it start coming from the your puncture site. So definitely, it is not possible to repair them intraoperatively. In those cases, we have to go for the open and we have to do the suturing of this dural tear.
Sir, I have shared a video of dural tear in FIAPM group. A student can see. This is not of mine. This is one of my friend. In which cases it was done. It is very nice depiction of dural tear. Everybody can see there. and very short video of 1 or 2 minutes, which is showing traversing root dural tear. And in this type of dural tear, we have to only wait and watch. We should not do anything. These are generally doesn't cause any harm to the patient.
Yeah, that is what we have to observe the patient. Basically, if you have found, even if you have found during the interoperatory there's a nick into this, then we can just wait and watch for some time. And but if it starts leaking from the puncture side, okay, don't wait.
Yes, sir.
Don't wait. Immediately send the patient for MRI, and it is better to take a surgical opinion. There is no harm in taking the surgical opinion. Let me tell you very well. Involve other specialists also.
Yes, sir.
Okay, because if you don't do that, that will be negligence.
100%.
Simple.
Taco seal and gel form. Somebody is asking.
Yeah, that is what they see. I've seen 2 cases in last 10 years where I sent this patient for the open surgical, because in my hospital I call my surgeon also, and I am always there in the surgery. And we do that. We do suture the dura, and over that we put the gel forms and the taco seal, the T seal. What do you call it? T seal. We put the T seal also and the gel form also. But suturing is, if it is a big tear, then we always do the suturing. We just don't rely on the T seal or the gel form.
Sir, I have shared the 2 papers which I have discussed. That one is suprailiac and transiliac comparison and classification, and one is decision making between transforaminal and interlaminar disectomies in the FIAPM group.
Okay. So guys, go through that articles. Just go through the article. You must know all these things.
Yes, sir. I think, sir, questions are over. We can conclude the session right now.
Okay.
Yes, sir.
Chalo. Okay. Thank you. Thank you, guys. Thank you.
Thank you, sir. Thank you, sir,
Thank you so much.
for covering such a nice topic. Thank you, sir.
Bye-bye.